All right, good afternoon. I'm your last speaker before break, and we're going to do little ones now. All right, so just a quick introduction. I'm Sujit Iyer. I'm a pediatric emergency medicine physician, work in Austin, Texas at Dell Children's. We are a freestanding children's hospital, but we interestingly work within an adult hospital network. And so we have 9 community hospitals in addition to helping to run a fellowship. For the last 2 years, I've been working only with our community EDs to help with pediatric care preparedness. And so let me just, a couple disclaimers. Everyone in this room, we all know you are truly the real ER doctors in the room. I don't have to do much when these kids come in, right? I make one phone call and 9 fellowship boarded people come down to the ER. But what we know working in the community is that these kids always come to you guys first. And this is what we've been working on in Austin for the last couple of years, and so thanks so much for this opportunity. The plan is not to summarize all of pediatric cardiology in 45 minutes, but what I hope to give you is at least a framework on 4 or 5 bullet points that you just don't want to miss. 80% of all kids are coming to community EDs, and we're going to talk about the fact that you for sure have seen some of these kids in your life, even if you don't realize it. So we'll have time for questions at the end, but we're going to try to get through all 5 of these areas in the 45 minutes that we have. So we're going to review congenital heart disease. What do you do when a kid or an infant comes in and maybe is not diagnosed and maybe is presenting in extremis? How do you treat a kid who's had a congenital heart disease surgery? We're going to look at the basics of EKGs. Help me out a lot by covering syndromes, and pediatricians love syndromes, and we're not going to cover those same ones. But we're going to talk about the 5 or 6 things you never want to miss on a pediatric EKG. We're going to briefly talk about syncope, what you have to ask, and unlike maybe the adult side, peds is all history and physical. So we're going to talk about what you have to ask every time you have a pediatric patient with HMPs, and at least what you have to document for medical legal reasons. And then we're going to briefly talk about one other disease, and if nothing else, if this is not useful, your last 2 slides is a personal and departmental checklist for you to take back to really think about how you take care of these kids or how you may take care of these kids if they come in to your ER. So are you going to actually take care of these patients? I would argue if you've seen 100 kids last year, you've already taken care of them. 1% of all kids are born with congenital heart disease, and 25% of those kids actually have a critical congenital heart disease, meaning they need surgery or they need a catheter procedure within the first year. And 1/3 of those kids we miss in the newborn nursery. And we're going to talk about why that happens. This is all you need to know. This is all we talk about with the fellows and the residents. You only need to approach every case in these 5 major domains. So we're going to take a minute reviewing this approach for any potential cardiac case. Any infant that you walk in the room and you may be thinking cardiac, these are the 5 things that you need to think about, and we're going to talk about this in a case-based format. So age. Are they less than a month or are they greater than a month? Remember that ductus arteriosus thing? That thing usually keeps them alive right when they're born, but closes right around 2 or 3 days of life and completely closes by 2 or 3 weeks of life for most congenital heart lesions. Also, what's happening in the first month of life is the pulmonary vascular resistance starts to dramatically drop. So now, whatever's going on in their heart, the blood flow is going to preferentially go to that right side. That's not so good if you have a left-sided heart lesion. Color. They only come in 3 colors: blue, gray, and pink. Blue kids, they have a right-sided obstructive lesion. Gray kids, they have a left-sided obstructive lesion. And pink kids are probably in heart failure. And those kids probably look the best, and we'll talk a little bit about how you may pick those up. On your exam, there's actually only 4 things you really need to do on your exam every time. As soon as you walk in, look at their work of breathing. Cardiac kids, they're tachypnic, but they don't have retractions. You put your stethoscope on them, their lungs sound normal. You check their pulses. Always check their pulses. Brachial and femoral, looking for a delay. Always ask for someone to do a preductal, right arm, and postductal sat. That's your 3rd part of your exam, right arm, left foot, and you listen to the heart. You do those 4 things and you can categorize what type of cardiac lesion they probably have. Tests and interventions are actually even more simple. Every kid gets a chest x-ray and EKG, and there's only 3 interventions. It's fluids, how much, and do you give them? It's oxygen, how much, and is there ever too much? And it's prostaglandin. That's it. That's all of pediatric cardiology in the first 3 minutes. Don't tell any of the pediatric cardiologists that I work with that we said that. But it's really that simple from an ER point of view. So let's go through some cases. We'll talk about some diseases, and hopefully I won't run too long. So these are all real cases, by the way. some of which presented at our hospital, some of which presented in our community ED. So our first case is a 9-day-old who presented with poor feeding, and the mom noticed actually blueness around the lips during the feed. Kid looks okay now. So quickly, you're thinking this kid is less than a month. And before we get into any of these cases, let me just actually pause for a second. Quick disclaimer. It goes without saying, we're here for the heart course. We're not here for the sepsis course or the trauma course. So in your differential diagnosis for every single one of these cases, it's sepsis, it's trauma, it's infection first. But for the purposes of time, we all know what we're thinking about here. So this kid's less than a month. You're thinking something may be closing, and you're already thinking cardiac. This kid's blue, and you're thinking this kid may have a right-sided obstructive lesion. And you note that the blueness is actually around the face, not just around the hands and the feet. So this is real blue, not fake blue, not kid that was unwrapped. And you think about your 4 parts of your exam. On pulmonary exam, the kid's tachypnic, but lungs sound normal. You do the pulse ox, and it's 75% on the right hand, and it's 75% on the left foot. And that's real. You look at circulation, and the heart rate's fast, and you hear a harsh murmur on the right side, but there's no pulse delay. So as your nurses are grabbing oxygen, you're only thinking about 2 things. Get my chest x-ray and EKG, give some oxygen, do I have prostaglandin, and can I get an IV? So let's talk about those interventions. Oxygen is important and life-saving for these kids. Many people are scared to give oxygen for an undiagnosed cardiac child. But the take-home point is this. Oxygen will decrease your pulmonary vascular resistance. And for right-sided obstructive lesions like what this kid has, it's going to preferentially shunt blood to the right side of the heart. Your goal is not 100% SATs. Your goal is somewhere between 75 and 85%. And if you remember nothing else, anytime a cardiac kid who's a child walks in, that's your goal. Your goal is not 95. Your goal is usually somewhere between 75 and 85%. Fluids. Both right-sided and left-sided obstructive lesions are extremely preload dependent. A kid vomits 3 times, and all of a sudden they look bad when they're a cardiac kid. So giving fluids is safe. In these kids, though, we usually give them in 10 cc per kilo aliquots. Once I get around 20 to 30 cc's per kilo, I'm getting worried, and I'm calling my cardiologist, because that tends to be a lot of fluid for these cardiac kids. On test, we're going to talk about what RVH looks like in kids. In a right-sided obstructive lesions, you may notice a normal chest x-ray, black lungs because there's not perfusion getting out to that lungs, or more classically, a boot-shaped heart from right ventricular hypertrophy. And the question really, the first question should be in your head is, would you give this kid prostaglandin? And hopefully the question in your head is, can you do it in your ER right now if you go back home? And my argument would be that you need to be able to give prostaglandin in every community ER across the United States, because these kids will present to community EDs first. The answer is yes, this kid gets prostaglandin. And the take-home is any child who presents in extremis in the first month of life, after you've already given those antibiotics because you're recovering for sepsis, and that kid's not responding, you are ordering or thinking about prostaglandin, especially in those first 3 weeks. There are side effects. Hypotension and apnea are the most common. We always aim for a second peripheral IV if you can, but anything you can do to actually fill up the tank before is useful. And we'll talk about the apnea part in a second. I'm not going to go over this recipe, but maybe as a take-home is if you have a site that doesn't know how to make prostaglandin, you can easily steal this slide, take it to your P&T committee, take it to your nursery, and see if you can get it on any type of protocol here in your ER. Okay, so let's review. This is an older kid who had the same disease as the child who we first talked about. You'll notice that the heart looks a little boot-shaped. You may also notice that the aortic arch actually looks just like it should be on that side, but it's on the right side, right? And 20% of these kids will actually have a right-sided aortic arch. And there's the boot. And this kid has Tetralogy of Flow. I'm not going to explain every congenital heart disease. I'm not going to have time, but we're going to shine a little bit of a light on Tetralogy of Flow because it's really a shining example of why would these kids ever present to your community ED? Why do we not pick these kids up earlier? So Tetralogy of Flow, in the most simplest form, is a child who's born with an aorta and a septum that is just a little bit too far on the right side. And by virtue of that, there is an obstruction for the right ventricular outflow tract. But they come in varying shades of gray. A kid who's severely obstructed, they're blue in the first couple days of life. We tend not to miss those kids. However, if they're not too obstructed, all you're going to hear is their VSD murmur. And because pulmonary vascular resistance is so high, blood flow will actually go to the aorta and pulmonary system equally at the beginning. And then their PDA closes, pulmonary vascular resistance drops, and that's when you can get in trouble. And we're going to talk about when this minor obstruction can become acute, and that's called a Tet spell. In the most minor of kids, they can have pulmonary overcirculation. That's when the obstruction is very mild, and it's from that VSD that they're getting so much blood flow to their lungs. So let's talk about a Tet spell as a highlight of certain cardiac emergencies that can walk into your door. So Tet spells happen because kids are kids, right? So you sneeze at them funny, and they do funny things, right? So for usually the classic case is a kid got mad. They got angry, they got fussy, they threw up, and all of a sudden this septum right here acutely obstructs that right ventricular outflow tract. If it doesn't relax, they get dizzy, then eventually syncopize, and if they really don't relax, they'll go into cardiac arrest. But there are things that you can do to fix this. The overall goal for this is that you are trying to shunt blood through that outflow tract obstruction. And the keys to management are you're going to either increase afterload on the left side of the heart, or you're going to decrease resistance on the right side of the heart. You take those babies, you take their knees, and you quickly put them right up to their chest. That increases afterload. If you go overseas to third world countries, you'll find a lot of kids walking around with TETs that are 4 or 5 years old that have just learned to squat. And they'll just intermittently squat to actually relieve their obstruction. You give them oxygen because it actually dilates that pulmonary vascular resistance. You give them fluids because we know they're preload dependent. And you give them pain medicine. We use intranasal medications in Austin like water. If you don't do it already, I would highly recommend you do it. It's much easier than an IV. Give them some intranasal fentanyl and Versed, and that alone will probably cure most Tet spells while you're calling your transport team and your pediatric cardiologist to get them out of your ER. In most extreme cases, we do sometimes start beta blockers and phenylephrine to actually increase the afterload. So that's right-sided heart lesions. It's everything you need to know. Give prostaglandin, give oxygen, know about TETs. The other reason you need to know about TETs is we don't tend to fix them until they're about 6 months old. So those kids, a common theme in most pediatric congenital heart diseases, we don't always fix them right away because we need them to get bigger. And so when they present with acute illnesses, these kids are usually living in the community. All right, so let's move forward to left-sided heart lesions quickly. We're going to review the same 5 domains that you already know. This time they look sicker. 3-week-old comes in, gray, poorly perfused, immediately statted back. You already know your differential diagnosis. Sick 3-week-old, I'm giving antibiotics, I'm thinking about hypoglycemia, and I'm thinking cardiac. They're gray and they're in shock, and if it is cardiac, you're thinking that they're having trouble on the left side of their heart. On their exam, you notice they're tachypnic, but their lungs sound normal. Your risk of cardiac disease is now going up. You check their right hand sat is 92%, and your left foot sat is 75%. That's pretty big differential. All right, a differential of even greater than 3% between your right arm and your left foot is abnormal in the newborn nursery, and that's a big gradient. You check the circulation, and you notice a pulse delay, and you hear a harsh murmur right at the right upper sternal border. And you already know what you're going to do. You tell the nurse without even thinking, chest x-ray, EKG, oxygen, fluids, prostaglandin, let's start moving, and let's get the transport team. So you know this kid is cardiac because we're here, but also because of the clues on your exam. This is the one where I think sometimes people freak out, or as I know our nurses do all the time, where the cardiac kid comes in and they say, don't give too much oxygen. And they're right mostly, right? So if you give oxygen to this kid who's got a left-sided obstruction, you are going to dilate their pulmonary vascular resistance, and you are going to preferentially shunt blood to the right side of their heart. Not what you want to do. But again, your goal sats are 75 to 80%. That's your goal. When you get there, you stop. Anything more than that can do damage, but that's your goal. And if that's the only number you remember, you'll never do any harm. You're going to give prostaglandin, and we already talked about that. You're going to give fluids, and you're going to look at a chest x-ray. In this case, you may see cardiomegaly, and you may even see white lungs because that pulmonary vasculature, those pulmonary veins don't have a method to empty out into the left side. For those who have advanced ultrasound skills, you may even notice, you can look for 4 chambers and see, do they have 2 ventricles or not? You can look for septums, and you can look for global cardiac function. This is one left-sided heart lesion, aortic coarct, which is important to know because 40% of these kids are missed in the newborn nursery, even with an abnormal exam. So we know that kids, even with pulse delay, we miss them all the time from newborn nurseries. This is an older kid, obviously, and when you've lived a long time, you develop collaterals. So this kid has very subtle rib notching right there from intermammary vessels that have developed, and has the classic figure of 3 sign with the dilation of the subclavian before the coarc, a little bit of a tucking in of the coarc itself, and then a dilation post the coarc itself. All right, so here's the kind of the bread and butter shining example of left-sided heart lesions, hypoplastic left heart. Again, you never have to memorize this picture. That's not the point. But the reason why you need to know what this disease is that you need to know that it's high risk. Hypoplastic left heart represents 1% of all congenital heart disease, but represents 40% of all the kids that are going to die in the first 2 months of life. These are the kids that don't make it. Even with good surgery, only about 60% of them make it to 5 years of life, okay? So what's going on here? It's the same thing as with other congenital heart disease. There's usually a honeymoon period where they look great. In this case, these kids were born with really no left side, no left atrium, no left ventricle, and no aorta. So that right side is doing all of the work and having to pump through the pulmonary artery and through this ductus out to the rest of the body and through here to the lungs. And they look great until right at 3 weeks of life. What happens? That ductus closes, the pulmonary vascular resistance drops, and now everything is pushing blood to the lungs as opposed to the rest of the body, and they can present in shock. The other reason why you need to know about these kids is that even when we fix these kids, they are still tenuous. And so I want to talk a little bit about their surgeries only as a highlight of what you should be asking every patient whose parents say, my kid had heart surgery. So this is just an example. So hypoplastic left heart, when they fix them in the first week of life, what they do is they build a new aorta, which is amazing. They do it on a 4-day-old. They build a new aorta, and they insert this little tiny 3-millimeter shunt. That shunt is now the only source of blood flow to the pulmonary vasculature, okay? And the reason you need to really understand this is that most of these complicated heart kids are done in palliative repairs. And many of them are very dependent on things like these shunts, which is called a BT shunt, to actually get blood flow. And so there's certain things that if you just ask in the history, if a kid with a hypoplastic left heart comes into my ER and they're between stage 1 and stage 2 and they sneezed, I'm not sending them home, okay? Because these are the kids who even a little bit of decreased blood flow through that shunt, a little bit of dehydration, and they can have an acute crisis. And we actually admit almost all of them, okay? And so let's transition that into who should you send home and who should you keep? And we all feel comfortable now, prostaglandin, IV fluids, oxygen. You guys know how to take care of every congenital heart disease if it's not diagnosed in the first month of life. But what about the kids who already have a diagnosis? So this 5-month-old is a real case, known Tetralogy of Flow, presents. He vomited twice with the nanny. He looked a little bit dizzy, and you're already thinking, I remember that thing, that Tet Spell thing that we just talked about 4 slides ago and that I learned about at the heart course. And you notice on the vital signs that they're actually not that bad. A little tachycardic, not too tachypnic, blood pressure normal for age, nice mixing sat of 85%. And this kid looks great, playful and happy, drinking, maybe lips are dry, harsh murmur. And the parents are like, we are going home. I got my bag packed, I got kids at home. And the question is, can this kid go home or not? They just vomited a couple times. And the answer actually in this case is probably no. Here are the things that you need to be wary about in any kid with congenital heart disease or partial repair. Remember 2 things. Kids, when they're sick, they always come in with the same 2 chief complaints, right? They're either coughing or they're puking. It's always the same 2 things, no matter what the disease. That's all the pediatrics right there. But in cardiac kids, remember that URIs cause pulmonary vasoconstriction. So any kid who's got a right-sided cardiac lesion, you should be nervous, okay? Any kid who's vomiting, and I'll tell you right now, in all the years of doing pediatric EM, I cannot tell you what a kid's hydration status is based on exam. It is useless to think that we can assess hydration based on exam, but you can do it on history. Exactly how many ounces did they take in? Exactly how many wet diapers? How many times did they throw up? You have a history of dehydration by that alone, and that's enough in some high-risk conditions that we will bring kids into the hospital, and at the very least, you should talk to their cardiologist. Here are 5 high-risk conditions that are no-brainers for us that we admit every time. But really, they're just highlights, right? So kids who are in between stages of surgery, hypoplastic, I already mentioned to you, are high risk for death. Any kid who's a heart transplant, pre or post-op, we call their cardiologist. Any child who has a sign of shunt occlusion. We reviewed one type of shunt. But what is a sign of shunt occlusion? The classic signs of shunt occlusion are obvious. Drop in sats, drop in blood pressure, don't look good. But you should, if a parent says my kid has a shunt, you should always be listening for a continuous murmur, usually in the upper sternal borders. If you don't hear it and you're concerned, you should talk to the cardiologist and ask, should I be hearing a shunt murmur? Unrepaired Tetralogy of Flow, we already talked about, are high risk. And even if the parents know nothing, if they say, I'm due for another repair soon, and they're less than a year old, they're likely undergoing some palliative repair, and you should be talking to their cardiologist. We'll talk a little bit about some quality improvement stuff we've done locally to help with that. Okay, so we're going to talk about one more sick kid, and then we're going to try to hopefully have enough time to talk about the less sick cardiac kids too. So this is a 4-month-old with hypoplastic left heart in between stage 1 and stage 2. Easy. You already know they're leaving your ER, right? You don't even have to get past that line, all right? They're sick. They need to leave your community ER. But you notice the kid has bronchiolitis symptoms, decreased PO, 2 wet diapers. The child's tachycardic. He's tachypnic. His blood pressure's okay. His sats are 78%. You remember me saying between 75 and 85, you're probably okay. He's alert but fatigued, and he's working to breathe. Suprasternal, intercostal, subcostal, all of them. Crackles, intermittent wheeze, and everyone in the room is nervous. And as you're calling transport, your nurses ask you for the 5th time, should we just intubate this kid? Because nothing takes away stress like a person who's paralyzed, right? But the answer is probably no, okay? So when it comes to pediatric cardiac kids, you really need to think twice, maybe 4 times before intubating a pediatric cardiac kid. And why? Because this is what happens. You put any pediatric patient, but especially cardiac kids, on positive pressure ventilation, 2 things are going to abruptly happen. You're going to immediately decrease their preload and their venous return, and they will code. And you're going to actually increase pulmonary vascular resistance, putting them into some type of pulmonary hypertensive crisis if they're not already in one. But sometimes you need to intubate. So do you intubate every kid that gets pushed on prostaglandin? The answer is maybe. So if you're going to make yourself a to-do list for when you go back home, talk to your local cardiac program. The practice here varies wildly. It used to be an old practice that we used to say intubate every single one of these kids. The literature has clearly shown that there are pros and cons to this. In our institution, we say prepare for intubation. We will send our transport team, and sometimes they will be the ones to intubate. But if you do have to intubate, if a kid's coming in extremis, some key tips. You want to give medications that are going to have the minimal hemodynamic side effects. Etomidate is probably the drug of choice for us in kids. If it's a kid who's not known to have a cardiac disease and you're worried about sepsis, you may want to call the pediatric ICU doctor and say, listen, I know you're going to get mad. I'm about to cause adrenal insufficiency with this etomidate. Would you prefer me use fentanyl and Versed? It's a conversation that's better to be had as part of a protocol, maybe not in the middle of a code. All right? You're going to maximize preload. I always give these kids 10 cc's per kilo aliquots while I'm getting everything together. And only one person is going to attempt, and they're going to attempt it one time, and they're going to get it on the first attempt. That may be a neonatologist in your building. That may be you. It may be an anesthesiologist. But developing a protocol for these types of kids is a good idea. And just always have epinephrine at the bedside. We're not going to talk about push-dose pressors here, but the likelihood of these kids coding or going into some type of arrest is actually pretty high. Okay. So that's the sick kids. That's all congenital heart disease. I got about 20 minutes here to now go into most of the more benign things that you may see, because I think the second most common question we get, besides what do I do with these complicated, we won't use the word train wreck cardiac kids, is what to do. Now you know what to do. But the second is, when do I need to refer? All right. So we're going to get into the exam, EKGs, and then we'll be done. So murmurs. 75% of kids are going to have a murmur prior to the time they enter junior high. Most of them are going to be benign, okay? But what are murmurs that are pathologic that should warrant a cardiac referral? Here are your 6 things. These 6 things alone encompass about 80% of all pathologic heart lesions. So, does the murmur obscure S2? Is it pansystolic, meaning obviously all the way from S1 to S2? If you put your hand on their chest Do you feel a thrill? Maybe. I still don't know what a thrill is, okay? Let's be honest. The kids, you put your hand on your chest, you can feel everything, okay? But is their PMI off? Is it more upper than it is lower? Is the murmur harsh? Do you hear an early mid-systolic click, which may be a sign of aortic valve disease? And is S2 abnormal? Any of those things, refer them to cardiology. Even if you're not confident with that, and all of this seemed like a big mishmash of lesions, remember, this is all a pediatric congenital heart disease right here on this slide. So 80% of all congenital heart lesions are these diseases right here on the board. And I would argue that only the bottom 5 make you sick, and you already know how to take care of them. The first 3 are all cyanotic heart diseases, right-sided obstructive lesions. The last 2 are left-sided obstructive lesions that are either going to present in extremis as an infant, or they're going to present as syncope. And you already know how to take care of kids with syncope. So let's focus a little bit on pediatric EKGs, because you are going to be getting an EKG on all of these patients. I'm going to try to highlight just some little touch points on things that you may want to add to your repertoire when you're looking at a pediatric EKG. Amal already did a great job reviewing syndromes. Every pediatric person loves to hear the word syndromes, right? Because that's all we do is try to pick up syndromes. If you don't remember anything else, as part of your attachments, you received a reference card. That reference card has normal standards that we use always in reading our pediatric EKG and can help you as a guide when you're trying to think about what to look at next. Make sure, now I put measure your own QTC kind of as a joke because of the last presentation. The EKG actually does do a pretty good job even on the little kids, but I think the highlight here is that if you see one that's over 460, and we're going to talk about it, in the face of syncope, because so much of pediatrics is picking up screening congenital diseases, we usually still measure it and then call the cardiologist at the same time. And I'll talk a little bit about pediatric cardiology ovaries at the end when we talk about a safety checklist for your own site. All right, so here are the 4 domains we're going to review: rate and rhythm, intervals, QRS and P-wave access, and hypertrophy. And that probably covers most of the things you don't want to miss. So let's take this first case. 10-year-old, chief complaint of chest pain. Your resident comes up to you, or your nurse comes up to you and says, I noticed these clusters of beats, and then a big pause, and then a normal beat. And the question is this normal or not? And of course, most of you guys recognize this, just like you do in your young adults, a sinus arrhythmia, right? Just remember, in kids, it's the same as adults. For rate and rhythm, are you stable or are you unstable? Are you too fast or are you too slow? And when it comes to fast and slow, just remember that the cutoffs for kids are different. In general, little kids, greater than 220, so meaning less than a year of age. Older kids, meaning over a year, greater than 180, we start to be concerned about supraventricular arrhythmias. Or is it too slow? Remember again that the cutoffs are different in kids. Less than 100, less than 80, and less than 70 are our most common cutoffs. But what about this kid? Also, your nurse or resident comes up to you and notice the clusters of beats. But this time you notice the drop beat, right? Right there. That's pretty obvious. And you go back and you remember Amal's talk about intervals and how you really need to look at intervals no matter where they are. And you notice that the PR interval in the first beat in the cluster and the PR interval in the last beat in the cluster are different, right? So this kid has a second degree, what we call type 1 or Wenckebach. And I want to talk about this because we are taught that this is normal, and it is normal in a context. So just remember again with intervals, PRs, you want to know if they're too short or too long. QTs, the normal cutoffs for pediatrics are around 450. Our cardiologists, much like Amal said, get excited after it's over 500. But really, after 460, so if you take all of the children born with congenital QT syndrome, their average QT is around 470. So you got to put the EKG in the context of the history. They come in with syncope, and you see a QT of 465, 470, that warrants referral, okay? If the kid has electrolyte abnormalities and has a QT of 460 and didn't come for syncope, maybe not so much of a concern, all right? Other red flags, we talked about short PR already in our last presentation. Long PR is also equally a concern, first degree AV block. Second degree type 1, so that was the slide we just showed, right? Prolongation of that PR, then a dropped beat, what we call Wenckebach phenomenon. In a person with high vagal tone, normal. You're an athlete, you're a kid who's about to have a bowel movement, You're a kid who's sleeping, normal. But most kids who get their EKG in an ER are not in a low-stress environment. They're usually awake, unless you get lucky and you get one on a sleeping child. And so you have to put it in context of how the EKG was taken. A kid who's wide awake, who's maybe even a little bit anxious, who has that, warrants referral to cardiology. Second degree type 2 AV block is when there's not that prolongation, but there is just a dropped beat. And of course, dissociation always warrants referral. Those who live out east and see Lyme disease are very used to that, and of course we see that in kids also. All right, so let's talk a little bit, and again, I'm just hitting the highlights here. We can talk more about arrhythmia management. We're going to only focus on SVT management for the purpose of this talk, because frankly, if you're ever going to manage a kid with arrhythmia, that's going to be the most common one that you're going to see, and we'll talk about that in just another slide. So this time, your resident was very astute, heard an abnormal murmur, heard a harsh systolic murmur with obscuring of the S2, and said, I'm getting an EKG, that's not normal. And what you immediately recognize after you notice a normal rhythm and a normal rate with the P wave before every QRS is you notice that the QRS is upright in 1 and negative in AVF. And you start to remember that that's not normal, but kids have funky axes. So is that abnormal or is that not? And they're born so weird with the right side all big. And so you go back to your card and you actually look at the QRS axis, and you can clearly see that kids have right ventricular dominance all throughout infancy. In fact, it's not until they get to about 6 or 7 that they finally convert to the normal adult 50-degree QRS axis. So using that card will save you. But one thing that's never normal is a child who has an axis that's negative 60 degrees or more in this northwest quadrant is highly specific for congenital heart disease. So you see upright in 1 and negative in AVF, you should be thinking congenital heart disease. Kids who are in this northwest axis, so this quadrant right here, are classic for either a large ASD or an AV canal defect, commonly associated with Down syndrome, but you can have it without Downs. AV canal defects are when your ASD and your VSD don't really form normally, and that entire cushion right there does never really quite form properly. Sometimes the way that we really pick it up before we hear the murmur is on their EKG. So just remember, use the card, look at the axis. Northwest axis are abnormal. Okay, we're gonna kind of jump through these two because we actually talked a little bit about HOCM in the last talk. But the question is this abnormal? 10-year-old male, chest pain, has costochondritis by exam. You touch his chest, he's got costochondritis. But the machine says possible biventricular hypertrophy, possible LVH. And the one thing about pediatric EKGs is that the machine classically exaggerates LVH. It is not the greatest tool to pick up LVH. And in pediatrics will often, and the reason is kids have thin chest walls, and as was mentioned earlier, they have very muscular hearts. So when do you diagnose hypertrophy? When does it matter? Well, you're going to use your card. So your card actually has reference standards for R waves and S waves in both V1 and V6, which are the two leads that we're looking at the most. But I'm going to talk a little bit about some highlights that you should focus on when looking for hypertrophy in kids. So for RVH, 95% of your attention is going to be in V1. All of these findings are pathologic if you see them in a pediatric EKG. So let's walk through them. So kids are weird, right? So their T waves actually, after about the first week of life, becomes negative. And not until puberty or prepubal age do they flip to become upright. So an upright T wave in that age frame is abnormal. An RSR prime with R prime taller than R wave in V1 is abnormal. And any pure R wave or a QR pattern in V1 in a young baby is abnormal. And this is what it looks like. You see this child who's got a Q wave. It's not very wide, but it is there and it is present, and then a very dominant R wave. This kid actually ended up having a cyanotic heart disease. So it wasn't really that hard to diagnose because the kid was also blue. LVH. So as I mentioned, LVH in general in kids, EKG is not the greatest tool, but there are some red flags that you just can't miss. So if the R wave in V6 is intersecting the baseline of V5, that's not normal. And that is not thin chest wall. We tend to focus a lot on ST and T segment changes that are abnormal. Things like T-wave inversion where there shouldn't be, ST changes where there shouldn't be. In general, your mid-precordial leads are going to be the ones that overcall it. So this kid who has LVH has a classic sign of their QRS intersecting the baseline of V5. And that actually also has some T-wave strain in the inferior leads and one in AVL. Even if you don't remember any of this at all, you can always look back at that card and look at the column that says R over S ratio. And you're going to look at it for V1 and you're going to look at it for V6. And those are the two leads that we focus on most for looking for abnormalities that may point to hypertrophy. All right, I think we have a couple minutes here to actually go into SVT, then we're going to talk about syncope and just kind of wrap it up. So, you guys know how to manage SVT. I just want to highlight a couple things about pediatric SVT that comes up often, especially when we get phone calls. So again, stable versus unstable, fast versus slow. Remember that kids, when they get SVT, have something usually congenital going on, right? Goes without saying. And these are the three most common mechanisms of why they get SVT. They have an accessory pathway. Classic is WolffParkinsonWhite, right? The impulse starts in the sinus node, goes down the ventricles, and then comes back up that accessory pathway, causing SVT. They may actually have reentry within their AV node, or in kids with congenital heart disease, they may actually have an ectopic focus where they had their sutures or where they had their surgery in their atria. And we'll talk about that in just a second also. I think the key in why you need to remember this is that when you convert these kids for SVT, when you convert that kid into SVT, it's a great feeling, but if we're not able to capture that beat right during the conversion, the EP cardiologists sometimes have to wait up to a year to try to figure out which of those mechanisms caused it, and their recommendation on whether or not you get ablation versus medications is quite different. So recording when you actually convert these kids is really crucial, and we're going to talk about this. This is a classic SVT rhythm in a child who had actually WolffParkinsonWhite with no discernible P waves and a rate that's around 225. All right, so how do you manage it? You're going to record the EKG at all times because your cardiologists are going to love you. And the question is, do you do ICE or not? Our protocol where we are is that if you have a kid who does not have a diagnosis of SVT already, we try to obtain IVs. And the reason is that if you convert them with ICE, it is very hard to actually capture the rhythm. They tend to move and they tend to move around. But if they have a diagnosis of SVT, you may do ICE. So let's talk about vagal maneuvers. So any kid who's about to get ICE to their face, I always do three things. And it works. So in pediatric SVT, it's between 33 and 45% effective for regular old bread and butter SVT. But you're going to always do three things. You're going to make sure that ice bag has water in it so that it actually conforms to their face. You're going to apologize profusely to the family about what they're about to see because the kid's not going to like it. And you're going to get multiple bags. Every single part of that kid's face should be covered with ice except for their nose and their mouth, and you need to do it all at once. You do that, you will elicit that diving reflex, and they convert. Some kids even convert when you're trying to place the IV, but it definitely works, and it's definitely worth a try, especially if you're having trouble with IVs and things like that. But let's say you get an IV, and you're going to give adenosine. Just some quick reminders. You only have a couple seconds for that half-life of the adenosine. So while your nurse is worried about getting an IV, remind them, please try to at least aim for the arms, okay? Because if your adenosine fails, you are going to be wondering, is it because the IV was all the way down in the foot? Was it because the IV was tedious? So you want to get it close to the heart. You're going to double the dose after the first try, and you must have a mechanism to either push it with a three-way stopcock or have an immediate normal saline push. And this could be tricky, especially when you're giving low doses. So talk to your nurses about what your SVT protocol is before you have your first SVT case. For adenosine, that is for refractory SVT, so adenosine refractory SVT, this is what we usually do. We are calling our cardiologist as we prepare. I'm usually on my fourth or fifth dose of adenosine by the time I'm calling them because I don't trust the first three doses for some reason, and that's okay. It's a relatively safe medication. You're going to be doubling that dose. of all the medications that we use most commonly, actually amiodarone in pediatric SVT is the most common one that we use. I would not start this without talking to cardiology. If you start it, we start the infusion slow, and we do it over 60 minutes. It can cause bradycardia, it can cause nausea and vomiting. It must be slow. In general, pediatric EP cardiologists have moved away from procainamide with pediatric SVT, and verapamil is contraindicated because of prolongation of QT. All right. You may be asked by a pediatric EP doctor to start beta blockers. It's unlikely to actually convert the SVT, but what it does is it gets that myocardium to relax just a little bit, and then you give another dose of adenosine, and it's like magic. It's like all of a sudden now the adenosine works. So a little bit of beta blocker may actually be useful in these kids. Again, while you're calling for transport, while you're calling for transfer to a pediatric hospital. That child actually had WolffParkinsonWhite, and just like Amal said, actually has the delta wave most visible in V2, a little bit there in V3 also, but actually had prior EKGs where you can only see it in one lead. All right, we have a couple minutes. We're gonna finish up with one more arrhythmia, and then we're gonna close with the checklist for yourself. So, do kids get atrial arrhythmias? The answer is mostly no, but the kids who get it have all usually had surgery. So when should you be worried about an atrial arrhythmia? Be very scared when a kid who has congenital heart disease comes in with tachycardia and you don't know why. Many times the atrial rhythm can be buried, and we'll show an example here in just a second. And the reason they get it is because of the surgery itself. And so those kids are at high risk. Up to 40% of kids with Tetralogy of Flow and up to 50% of adults who have their ASD repaired over the age of 20 will go into some type of atrial arrhythmia at some point in their life. If they're stable, you call cardiology. If they're unstable, of course you'll have to cardio over, but you really need to get on the phone with your cardiologist. Many of our cardiac kids have many conditions that put them at high risk for clots, especially kids that have had Fontans. So this is a kid who actually had a Fontan, has a pacemaker, and has buried in here P waves that are both conducting and not conducting. So this kid's probably conducting at about 2-to-1, which is why you actually get a pretty good ventricular rhythm, but you're not getting the 225, 300, 350 rhythm that you may expect because of variable conduction. All right, we already talked a lot about syncope. I just want to highlight a couple things, and then we're going to be all done here. And the last talk was just a great summary on when you need to be worried about syncope. So kids with syncope, a little bit different, a little bit the same as your young adults, right? 80% of kids, the cause of their syncope is going to be autonomic. They're going to have vasovagal syncope. It's going to be a common chief complaint that you see in your ER. The other 20% are going to have seizures and migraines. So if they've had anything more than a brief loss of consciousness and your EKG is normal, consider whether or not the history could be attributed to seizures. Every single kid should get a standard set of questions on their history and exam. Orthostatic vital signs, upper and lower extremity blood pressure, looking for the coarc that may be missed. And we're going to talk about when to refer to cards. So here are kind of the red flag things that I always refer to cardiology. Do they have syncope with exertion? Do they actually have chest pain or palpitations either prior to or during exercise? Was the syncope triggered by something loud or something frightening? The classic history of children and families with prolonged QT, fire alarm bell goes off, it immediately sounds, and a kid drops and syncopizes. So auditory and visual stimuli in familial prolonged QT is a common stimulus for them to go into ventricular arrhythmia. And other things that we ask about are deafness. Some of our congenital QT syndromes are associated with deafness. And of course, family history, we always ask about, are there any people who had unexplained deaths like drowning accidents or single motor vehicle accidents, family history of arrhythmias? Or in the case of Brugada that we picked up this last year, all of the males had seizures, but in fact, they all had Brugada, and they just didn't know about it. And for some reason, they were all alive. Here are the things that you don't ever want to miss on exam. So you're looking for signs of aortic stenosis or aortic coarc, like a systolic ejection click, or an outflow murmur. Remember kids with hypertrophic cardiomyopathy? Classic flow murmur in kids, you make them squat, you increase preload, that preload increases flow through that nice healthy valve, and the murmur gets louder. Hypertrophic cardiomyopathy, they're obstructed, you make them squat, you increase preload, you actually relieve some of that obstruction, now the murmur goes away. Okay? So big difference between flow murmurs. You're going to look for blood pressure gradients, and all of these EKG findings we actually just reviewed in our previous talk. I'm going to talk just a little bit quickly about one more disease, and then we're going to be done. I'm going to wrap it up and leave you guys with a little bit of a checklist. So myocarditis is the thing that we all worry about every single winter time. It's uncommon, but when you look at kids on autopsy, up to 20% of kids who've had unexplained death had myocarditis. The classic findings for myocarditis are signs of heart failure. And in kids, we look for three things when we think about heart failure. Do they have hepatomegaly? Do they have tachypnea that is unexplained? And do they have a tachycardia that's unexplained? Those three things should make you a little bit concerned that this kid doesn't just have the flu. Evaluation is tough. This is all clinical suspicion. The most common EKG finding is sinus tachycardia, and it's a coin flip if you have an abnormal chest x-ray. Troponins and BNPs actually have not been shown to be predictive in any way. I only want to highlight it to just kind of bring this whole talk full circle to say, you guys do an unbelievable job of screening every day for these kids. We had a case this past year that got a lot of attention where a community hospital in the middle of flu season had a kid who looked like they had the flu, but he didn't quite look right. They noticed tachycardia that was unexplained. We talked on the phone and we both agreed something wasn't right about the chest x-ray. It looked a little big. We picked up that kid for transport. The kid codes in our ER when he tries to use a restroom, gets put on ECMO, has influenza myocarditis, and makes it. And I'll say all the attention was to the heart surgeons who put the kid on ECMO, but all of the credit goes to the community doctors. So make sure that you feel like you have a safety checklist for cardiac diseases in your kids, which just leaves me with these last couple slides. For yourself, make sure that you're comfortable with management of congenital heart disease after the first couple days of life. Do you know how to get prostaglandin into a kid in your ER? You know how to manage kids or contact cardiology who've had repaired congenital heart disease, looking at pediatric EKGs for the little subtle points, and you know what high-risk syncope things to ask for. For your department, I'll leave you guys with this. This checklist we actually take to all of our community EDs, and we make sure that every single one of our community EDs is comfortable in these buckets. And if they're not, we actually do outreach by bringing our cardiologist out there, by me going out there, and helping to increase communication and protocols between them and our transport team. Hope you find that useful. It's a lot of cardiology in 45 minutes. We'll have time for questions a little bit later. Any questions right now immediately? Yeah. No. Yeah, so I would say that in the first month of life, if you have a kid who's in extremis and you have already treated for infection, trauma, hypoglycemia, and the kid still looks ill, the question is why did that kid not have prostaglandin, not why you didn't give it. Yeah.